Hi everyone, this is Dr. Chen. I'm an ophthalmologist from the Joint Center International Eye Center. Today, I would like to share with you some common lacrimal disorders and disease. Our objectives include to be able to describe the anatomy of lacrimal system, identify the common disease of lacrimal secretory system, and a few abnormal conditions associated with the drainage system. First of all, let's have a look at the anatomy. Lacrimal apparatus includes the lacrimal secretory system and drainage system. The secretory component consists of major and accessory lacrimal glands, which produce various constituents of tear. The major lacrimal gland is composed of a larger orbital lobe and a smaller palpebral lobe. It is located within a fossa of the frontal bone in the supratemporal orbit. The accessory lacrimal gland is found in the conjunctiva, mainly in the superior fornix. It produces the aqueous layer of tear film. There are 4 parts in the lacrimal drainage system. The puncta are the openings of the canaliculi. We can identify them in upper and lower eyelid near the inner caphens. The canalicular pass vertically from the lip margin for about 2 mm and then run horizontally for about 8 mm to reach the lacrimal sac. Lacrimal sac is about 10 mm long and sits in the lacrimal fossa in anteromedial wall of the orbit. A downward extension of lacrimal sac, called the nasal lacrimal duct, about 12 mm long, enters the nasal cavity. Opening of the nasal lacrimal duct is a mucosal flow called valve of Hassner. Acute inflammation of the lacrimal gland is a rare condition, most often seen in children as a complication of mumps, measles, or influenza, and in adults associated with gonorrhea. The patient presents with rapid onset of considerable pain and swelling at the temporal aspect of the upper eyelid. Swelling of the lateral aspect and the eyelid overlying the palpebral lobe leads to a characteristic S-shaped ptosis. There is tenderness over the lacrimal gland, and injections of the conjunctiva overlying the palpebral lobe may be seen on upper lid eversion. Chemosis may be present. Treatment varies according to the cause. Systemic antibiotics or antivirals can be given if bacterial or viral infection is present. Sometimes we need surgical drainage to eradicate the infection. Chronic dacryoadenitis may be the result of benign lymphomatic infiltration, lymphoma, leukemia, and tuberculosis. It is usually asymptomatic, has a less acute onset, and involves both eyes. Patients may complain of double vision in severe cases if the enlarged lacrimal gland affects eye movement. It appears bilaterally as a soft mass in the supratemporal quadrant of the orbit. Treatment for chronic dacryoadenitis depends on the primary disease and severity. Steroid may be adequate in some cases. If it doesn't work, surgical extraction is sometimes indicated to relieve the symptom. Now let's turn to disease and disorders of the lacrimal drainage system. The lower end of the nasal lacrimal duct in the region of valve of Hassner is the last part of lacrimal drainage system to canalize, with complete patency most commonly occur soon after birth. Congenital nasal lacrimal duct obstruction is caused by persistence of the Hassner membrane. Epiphyseal means tearing and matting of the irises may be constant or intermittent, and may be particularly noticeable when the child has an upper respiratory tract infection. Gentle pressure over the lacrimal sac may cause mucopurulent reflux. Secondary bacterial conjunctivitis should be treated with the topical antibiotics. Massage of the lacrimal sac has been suggested as a means of rupturing the membranous blockage. This picture shows us how to do massage. We can place the index finger over the common canaliculus to block reflux, and then roll over the sac, massaging downwards. For children over 6 months old with persistent symptoms, probing is indicated. This is usually regarded as the definite treatment. We pass a fine wire via the canalicular system and nasolacrimal duct to pierce the obstructive membrane at the valve of Hasner. One probing is effective in 65% of cases. For those that fail, we can repeat probing and consider surgery. Infection of the lacrimal sac is a common disease that usually occurs in postmenopausal women. It is most often unilateral. Acute dacryocystitis is usually caused by Staphylococcus aureus or occasionally beta hemolytic staphylococci. The chief symptoms are tearing and purine discharge. Redness, pain, and swelling are present in the tear sac area. Lavage or probing should not be attempted in this phase. Initial treatment involves the application of warm compresses and oral antibiotics. If an abscess is pointing and about to drain spontaneously, we can make a cut to facilitate drainage. Chronic dacryocystitis is always secondary to obstruction of the nasolacrimal duct. It is usually caused by Streptococcus pneumoniae infection. The patient usually has chronic epiphyseal and recurrent mucous discharge at the inner caverns. Relief of obstruction is the only cure. A dacryocystal anosmia is indicated. It consists of forming of a permanent anastomosis between the sac and the nasal mucosa to bypass the obstruction in the nasolacrimal duct. However, it's time-consuming. Dacryocysectomy, excision of the lacrimal sac, can be better choice in the elderly. Transluminal balloon dilation of the distal nasolacrimal system may also be useful for patients not suitable for surgery. In summary, lacrimal apparatus includes the lacrimal circulatory system and drainage system. Inflammation processes of the lacrimal glands and lacrimal sac vary with different causes. Treatment for the disorders depends on the underlying cause and severity. Congenital nasolacrimal duct obstruction is caused by persistence of the Hasner membrane. Probing is indicated for children over 6 months old with persistent symptoms. That's all for today. Thank you for your attention.